Hello, everyone. Welcome to this webinar. My name is Mary McCaskill, and I'm a research director at the National Centre for Social Research. I manage the national evaluation of A Better Start, so I'll be chairing today's webinar. And just before we get started, I wanted to remind everyone that closed captioning is in use. So if you would like subtitles, then just click that function on the bottom right-hand corner of your screen. We're just waiting for the slides to come up. There we go. So we have a full agenda for our time together today. So this is our annual update of the national evaluation, and the focus today will be on the contribution analysis and how evidence from across the evaluation is coming together to form a mosaic of evidence to understand the contribution that A Better Start is making or has made towards the lives of children and families. I'll start by giving a brief introduction to the A Better Start national evaluation, and then I'll hand it over to my colleagues who will present draft contribution claims and discuss the evidence which is being used to develop them. While we're not in a position to present final results today, we are excited to share the mechanics of this complex evaluation with you and also give you a sense of what you can anticipate learning from the final report, which will be available next spring. So just a bit of housekeeping before I move on. Please use the question and answer function to ask questions throughout the webinar. We'll select a handful of questions that we'll be able to respond to today, but then afterwards we'll publish responses to all of the submitted questions alongside the recording of the webinar. We won't be sending out slides, but this webinar is being recorded and you'll be sent a link to the recording afterwards. So moving on to the next slide. A Better Start is a large program set up by the National Lottery Community Fund to support families to give their babies and young children the best possible start in life. It was delivered through 5 partnerships in Blackpool, Bradford, Lambeth, Nottingham, and Southend-on-Sea. And the outcome areas that A Better Start focused on were diet and nutrition, communication and language, and social and emotional development, as well as systems change. The national evaluation is being delivered by a team that shown on the next slide. So it's being delivered by NatCen, the University of Sussex, RSM, Research and Practice, and the National Children's Bureau. And today with us, we have colleagues from NatCen, University of Sussex, and RSM, who are all leading on different pieces of the research activity. Next slide, please. The national evaluation has 4 key aims. Those are presented here. They are to draw upon the evaluation objectives, to provide evidence for primary audiences, and to provide evidence that can support grant holders as well as larger decision making within the fund and policy practice initiatives addressing early childhood development. The national evaluation also works with local A Better Start evaluation teams, both to avoid duplication of evidence and also to collate and synthesize evidence that is generated through other local evaluations. There are 4 evaluation objectives which are shown here that together are allowing us to develop a robust and comprehensive understanding of the impact of A Better Start. So we'll hear from colleagues from all 4 objectives today. So objective 1, exploring the contribution by A Better Start to children's life chances through a quasi-experimental design. the factors which contribute to children's to outcomes, which we've explored through qualitative interviews with a Better Start staff as well as non-ABS early years workforce and the fund. Families' experiences through a Better Start systems, which have been explored through longitudinal qualitative interviews and journey mapping with families taking part in a Better Start programs. And then the contribution made by ABS to reducing costs to the public purse relating to school children, which is being done through a cost consequence analysis that draws on existing evidence from cohort studies and economic evaluation. On the next slide, we have here's a Better Start theory of change. And this shows how our evaluation is being used to build a mosaic of evidence. So the mosaic of evidence is represented here by the squares, triangles, and circles, which align with different elements of the theory of change. So I'm now going to hand over to my colleague, Mackenzie, who is going to present our approach to contribution analysis, which is underpinning the whole evaluation and the focus of today's webinar.
Great. Thank you, Mary. So as Mary said, underpinning our national evaluation are principles of contribution analysis. So what is contribution analysis? To put it simply, it's a framework of analysis which provides us with a systematic way of understanding how an intervention or a program might contribute to outcomes or impacts. So really trying to understand how a program works and contributes to outcomes. ABS is a complex program, and contribution analysis allows us to really lean into that complexity through creating a mosaic of different forms of evidence to evaluate the contribution that ABS has made towards outcomes for children and families, as well as to wider systems change, whilst also accounting for kind of inherent variation within different contexts and approaches to ABS implementation amongst the different sites. So to do this, we need to piece together different types of evidence that look at how ABS was delivered, the context that delivery sits in, how ABS interventions could then be a catalyst for a chain of events that might lead to outcomes. So using this approach, we really aim to provide a strong narrative as to whether, how, and why ABS contributed to change. So when using contribution analysis, we typically follow a 6-step iterative approach, which is what's on the slide here. So step 1 involves understanding the problem an intervention is seeking to address. So for ABS, this was done during the first phase of the national evaluation, where we undertook scoping work to understand the program more, the existing evidence and findings from the first evaluation, and finalize the evaluation aims and objectives. Then you move into step 2, and this is where we really needed to create a roadmap to better understand the different ways in which ABS might influence various outcomes. So we developed the theory of change, which Mary shared on the previous slide. So the theory of change really articulates the key inputs and activities of ABS, the intended outcomes that we expect to come about because of ABS, and then also the assumptions and the mechanisms that kind of underpin how we expect the program of activities and inputs to lead to those outcomes and impacts. And that could be factors both inside and outside the program that may influence reaching those outcomes. So really, the theory of change ultimately kind of provides that framework for the evaluation and is really a roadmap moving forward. So then in step 3, once we had our kind of initial thinking of how we thought the program might work and contribute to these outcomes, we began collecting evidence against that theory of change. So as part of a contribution analysis approach, you want to collect or collate evidence from a range of different sources. So this could include quantitative and qualitative data from lots of different people and sources, both primary and secondary as well. So this is what we've been doing through the 4 different objectives that Mary just spoke about. So during step 3 of the contribution analysis approach was really early waves of fieldwork for objectives 2 and 3, which make up that kind of 3rd step for us as part of the evaluation. So after that, moving on to step 4, once we had that kind of initial trench of evidence from objectives 2 and 3, we began assembling and assessing evidence against the theory of change and beginning to kind of develop that contribution story. Why do we think that these activities and outputs might be contributing to outcomes as outlined in the theory of change? So using this early evidence and the theory of change, we began to develop what are called contribution claims. So these are pathways which illustrate the causal links from the inputs and activities to outcomes and impacts with underlying assumptions, enabling factors as well. I'll touch on a little bit more on claims before we get into detail about them, but these are something that we developed in consultation with the objectives and the fund, and is something that we've kind of iteratively adapted throughout the process. So after step 4, this took us to step 5, which is seeking out additional evidence. So this was through the later waves of data collection for objectives 2 and 3, as well as gathering the available evidence for objectives 1 and 4. And this really helped. This was designed to kind of help fill remaining gaps in our understanding of ABS and that progress towards outcomes. And that takes us to step 6, which is where we are now. So we've been revising and strengthening the contribution story, and also working towards making an assessment of the overarching evidence that we have as part of that mosaic of evidence. So as part of this step, we've amended the contribution claims based on the new evidence from the most recent waves of fieldwork. And we're in the process of kind of bringing that all together, also with local monitoring and evaluation evidence as well that the sites have completed themselves. So we'll then consider, as part of this final step, the full kind of package of evidence against each of the claims and make an assessment on the evidence for and against each of the claims. So this will make up our contribution story of ABS, presenting our final contribution claims with their full explanations and considerations in the final report. So moving on to the next slide, I just wanted to comment further on 2 elements that I've just kind of discussed as part of that 6-step process. Firstly, I wanted to talk a little bit more about contribution claims, because it is a little bit of a different concept, I suppose. So what are contribution claims? They're a short kind of focused narrative of how we believe ABS programs generate outcomes. So they really are meant to represent a chain of cause and effect or causal chains, which we can evidence at each step to suggest how we think impact might have been brought about or not by a program or an intervention. So they're basically our hypotheses for how we think ABS might lead to change. For ABS, the claims will really allow us to kind of test whether, how, and why ABS might have contributed to outcomes. So we have looked at evidence across each of the objectives about how ABS interventions and processes work or don't work as well, and have joined up these pieces of evidence as contribution claims. So these set out a narrative about how the program inputs and activities contribute towards outcomes, providing a real testable and verifiable path to outcomes and impact. So within this narrative, we include mechanisms which we feel are kind of the things contributing to these changes, as well as assumptions or enablers, which we feel kind of must be in place to help reach those outcomes. So we've collected more evidence to critique this narrative to see if there's anything missing and if we might be making the right assumptions, and have updated the claims. So that was part of that step 5 that I spoke about. And this has allowed us to really build a credible contribution narrative, which has evolved in an organized and systematic way, but also an organic way alongside the emerging evidence that's come out of the different objectives. So moving on to the next slide, the other point I wanted to clarify before we move on to the claims themselves is about the evidence assessment. So again, this is part of step 6. And as part of that final step, as I mentioned, we're bringing together kind of the full package of evidence underneath each of the claims. So both the qualitative and quantitative evidence, as well as local evidence from the local evaluations as well. And this includes both confirmatory and contradictory evidence. So we're not seeking out just things that say, oh yes, this supports this bit of the claim. We're looking at kind of the full evidence picture. And then we'll make an assessment on the evidence for each of the claims. So as part of this assessment criteria, we're developing a framework, and that framework is considering several factors, including the things that are here on this slide. So the first is around strength of evidence. So does the evidence provide a clear connection between the intervention and outcomes? This element might consider, is there a connection? How strong is that connection? Is it thorough and convincing? Is that what the evidence is telling us? How many sources of evidence kind of support that connection, and how many different source types are there? And then also looking at things like credibility. So can we trust the data and interpretations? And also reliability. Is the data dependable, consistent, and robust? We're also looking at completeness. So is there appropriate evidence which speaks to the full narrative for that claim? So have we observed the appropriate evidence? Does the claim speak to the full narrative? Have any alternative explanations been considered? Has context or other influencing factors been considered as well as part of that? And then finally, plausibility. So are the chains and underpinning assumptions logical? Are they feasible? Do they make sense, basically? Are they informed by the research? Are they supported by stakeholders? And this element considers, is the pathway logical? Is it feasible given the gathered evidence? And do the assumptions that we've identified hold based on the evidence? So for each of the claims, we'll report on these elements and make an assessment on a scale, for example, high, medium, low for each of them. And this will ultimately make up our assessment of the contribution story and ABS's contribution towards the outcome areas. So if we go to the next slide, this slide summarizes the various outcome areas that we are looking at as part of the contribution analysis. So there's 8 outcome areas for which we've developed claims as part of the evaluation. So these were determined to be the most appropriate outcome areas based on our understanding of ABS, the program theory of change, and early findings across the objectives. So you see in purple there are 3 child outcome areas, and then in blue, there are 5 system change outcome areas as well. Today, we're going to present on specific pathways within the contribution claims that relate to the child outcomes, so the ones in purple there. However, you'll see that there is often a crossover between systems change and child outcomes, as really improved systems, while their outcomes of ABS in their own right, also serve as kind of a mechanism for enhancing child outcomes as well. But now we'll take you through each of the 3 child outcomes. What we're going to do is first, I'll explain kind of how we're presenting the claims, the diagrams that we're using. I'll then, starting with the first communication language claim, discuss the elements of the pathway we're focusing on today, and then each objective will come in and speak to how their evidence will work to form part of that mosaic of evidence for the full claim. If we move on to the next slide and the one after that. Great, thank you. So we'll start with communication and language. So as we've developed the contribution claims, we found that one helpful way to kind of illustrate these causal pathways is through using these diagrams or causal maps, which you can see on the slide here. So for each of the claims, the 3 claims outcome areas that we're talking about today, there are multiple, often intersecting pathways that could lead to the outcomes that we hypothesize could lead to outcomes. So today we're only going to cover one pathway per claim per outcome area, which is emphasized in the color here. So the other pathway has been faded out just for the purposes of the webinar. But to explain what we're looking at here, so for each of the diagrams, if you work back from right to left, so the purple box on the right represents the outcome area. So in this case, it's improved communication and language development outcomes. The green boxes represent the different mechanisms or the ways in which we hypothesize that ABS may lead to these outcomes. So this is really a very important part of that pathway. And then the blue box on the left kind of represents inputs or activities of ABS related to this outcome. So what are the things that ABS are doing that we feel are, starting off this causal pathway? And then finally, the pink boxes on the bottom represent preconditions, assumptions, or key enablers, which are allowing these inputs or activities to lead to these outcomes. So to speak specifically about this outcome area for communication and language, we hypothesized 2 causal pathways which explain how ABS might contribute to this outcome area. Today, we're going to speak about the second one, which is on the bottom there in color. So for this outcome area, the blue box suggests that through ABS services and support, connections have been made with early years providers. So we're hypothesizing that through developing relationships with and providing evidence-based training to early years providers, ABS has led to the creation of more language-rich early years service environments, as well as improved provider ability to identify additional needs and obtain referrals to appropriate specialist services, which has enabled children to access tailored and specialist support. For each of these, we hypothesize that leads to the outcome around improved child communication, language, and outcomes. So now, as we will for each of these claims, I'll hand over to Objective 1, to Lisa, who will talk through how the evidence from Objective 1 may speak to this pathway.
Thanks, Mackenzie. I think if we stay on the previous slide, so as part of Objective 1, we will be using a quasi-experimental approach to compare by comparing outcomes of children and families in ABS areas to those outcomes of children and families not in ABS areas, who will form an estimate of what ABS outcomes would have been had ABS not been funded. And with each of the child level outcome areas, we've identified specific indicators that relate to the outcome area, and I will be listing those indicators. So with the communication and language outcome area, the first indicator we're looking at is communication skills at age 2.5, or when children are aged 30 months old, whether they have reached the expected level of development on communication skills measured through the Ages and Stages questionnaire at 2.5 years. And then similarly, we also look at overall child development at 2.5 years, again, whether children have reached the expected level of development for their age, measured using the Ages and Stages questionnaire on domains in addition to communication skills. So we're looking at fine motor skills, gross motor skills, problem solving skills, and personal social development altogether, comprising overall child development. The next indicator we're looking at is school readiness at the end of reception year in school, so around age 4 or 5, covering again whether children have reached a good level of development across a range of domains, including communication and language development, but also physical development, personal, social, and emotional development, literacy, maths. Then at older ages, we're looking at Key Stage 1 attainment at the end of year 2 in school, so around 6 or 7 years, and covering whether children have attained the expected standard or greater depth in reading, writing, and mathematics. And then finally, we're looking at Key Stage 2 attainment at the end of year 6 in school, so when they're about 10 or 11 years old, and whether they have attained the expected standard or greater depth in reading, mathematics, and grammar, punctuation, and spelling. So those are the outcome indicators that we're looking at for this domain, and I'll pass over to Natasha for Objective 2.
Great, thank you. Yes, so Objective 2 involved interviewing practitioners and stakeholders who were involved in the design and delivery of ABS services. And ABS respondents talked about a host of formal and informal training opportunities for early years practitioners that aim to teach them communication strategies to use with children in their everyday interactions and how to meet children's individual learning needs. So these included universal interventions to support the development of all children. For example, there was a training for early years providers and Family Hub staff in Early Talk, which is a training program to support the communication of children from birth to age 5. And by training staff both in and out of formal learning environments, adults understand their role in creating opportunities for communication. And as a result, they also create more and higher quality interactions to develop children's language. ABS services also aim to strengthen partnerships between practitioners and families. And they did that through training practitioners to talk to parents and also carers about their children's communication needs. Ensuring practitioners have the confidence to advise parents is key for cascading the learning from ABS training and helps them to create language-rich home environments. ABS respondents also described training to support early identification of communication difficulties and delays. So one service trained health visitors to use the WellCom screening tool during their under 1 visits, which specifically assesses communication. And that led to an increase in referrals for specialist support, meaning that children with communication delays received targeted support earlier. And another key part of the ABS approach is joined up working and consistent messaging. And that's particularly important for communication and language. because practitioners told us that there's sometimes conflicting advice around that. So ABS services worked with partners to ensure that they were sharing the same clear evidence-based advice and strategies, and that included providing health visitors with information to share with parents who might be concerned about their child's language development. So in summary, ABS staff recognised the need to upskill practitioners and parents alike to ensure that they have the resources to both identify communication difficulties and to allow children to experience a supported language learning environment. So I'll now just hand over to Janet to talk about Objective 3.
Thanks, Natasha. So we've been in Objective 3, we've been talking to families twice a year. So we're just finishing our 7th round of interviews with families. And 10 of the families in the Objective 3 sample are multilingual. And I want to pick up on that because the early identification of language support needs is inevitably more complex when children grow up learning more than one language. So part of our analysis has focused on their experience. And I want to share an example from one multilingual household. Along with other examples in the Objective 3 sample as a whole, their experience over time shows why flexible relational approaches have been a key mechanism for engagement and impact in relation to communication and language. So this is a family who've had one-to-one support from a family mentor, and their experience over 3 years of interviewing has illuminated how the mentor role has enabled, first of all, identification of needs, secondly, access to more specialist support, and third, and crucially, the acceptability of that support for the family. So the interview we did when the child was 9 months old, the mother described getting advice about the child's developmental milestones. When she was interviewed a year later, there was some concern noted about low scores in relation to communication and language. But she again discussed strategies that had been shared by the family mentor that she was using in her everyday practices. And at the same time, she had a referral into an early language support service, so specialist service. By the time of our Wave 3 interview, which took place in 2024 in the summer, the child had used that service, but with the support of the nursery they were attending as well, had now been referred for speech therapy. So you can see, I think, in that account over time, how an ongoing model of support from the mentor facilitated access to relevant support services. But what was also striking in her account was that she talked about that in relation to the child's multilingualism. The mother is aware that language learning is more complex when children are learning multiple languages. So at one point, she said in her interview, maybe he doesn't really talk much because he still didn't choose which language to communicate with. And across her interviews, you can see that she's not necessarily totally convinced about the need for such service, but she was equally evidently pleased that it was available and trusted that it would be worth doing. We know from research that developmental trajectories for multilingual children are not the same as for monolingual children. So to ensure accurate identification of needs, practitioners need to have expertise in the speech and language development of multilingual children, an understanding of how this should shape approaches to early years support. What's crucial in the example that I shared is the mother's trust in the worker. It allows her to engage, even while she retains some skepticism about the necessity of the support. So I'll hand over now to Beth, who'll talk about Objective 4.
Thanks, Janet. Such a powerful example. For each of the pathways that you'll see today, I'm going to talk about how a Better Starts focus on prevention, early intervention, and systems change has the potential to create public benefit by enabling cost avoidance. Objective 4 aims to evidence the contribution that the programme has made to reducing costs to the public purse, relating to primary school age children. Our goal is to assess the value for money of this public benefit in relation to the costs of delivering the programme. Our approach has been to use existing cohort studies and economic evaluations to identify causal connections between the ABS outcomes being measured through Objective 1 that Lisa mentioned earlier, and the later outcomes and associated cost to the public sector during the child's primary school years. So if we take the first outcome that Lisa mentioned, communication, and that's measured as a proportion of children reaching the expected level of communication at age 2.5. So there is evidence that children with an at-risk ASQ communication score at age 2.5 are more likely to have speech, language, and communication needs during primary school, which leads to speech and language therapy intervention and associated costs. That means if, once the team have completed their analysis, they find that ABS has led to improvements in this outcome for participating wards or beneficiaries, then we can estimate the potential costs that would be avoided from reduced speech and language interventions for these children during the primary school years. Similarly, for the school readiness outcome, there is evidence that children who are not school ready at reception will require additional catch-up support whenever they during their first few years of school. So again, if Objective 1 finds that there's evidence of positive change, then we can estimate the potential costs avoided through reduced need for catch-up support amongst ABS cohorts. I'll pass back to Mary, who I think is going to take us on to the next domain.
Thank you, everyone. Yeah, listening to the examples and the evidence, I'm always really struck by when we discuss this claim about how it's underpinned by relationships, and we see those relationships at so many different levels, both within the families themselves, up through how systems interact to enable earlier intervention for speech and language. I'm keeping an eye on the questions just before we move on. There's been a few questions about the slides and why the slides aren't moving. So that's correct. The slides aren't moving. So the format for this for the presentations is we're going to have each causal claim up on the screen, and then the speakers will speak to that causal claim. But so it's just one slide per claim. And we're going to move on now to diet and nutrition. So handing back over to Mackenzie to discuss the claim for that outcome area.
Great. Thank you, Mary. Move on to the next slide. And the next one. Great. Thank you. So once again, I'll explain the pathway diagram, the causal map that we have on the screen here, and then each of my colleagues will speak to their objective evidence for this outcome area. So for the child outcome of diet and nutrition, we also have hypothesized two causal pathways to explain how ABS might contribute to this outcome area. Today, we're going to speak about the first one, which is on the top there in the color. So for this outcome area, the blue box here suggests that ABS services provided or facilitated interactive community activities and outreach for families targeted at parents or carers who have an influence over children's diet. And we have hypothesized, so what's in the green here is that this has led to parents or carers improving their knowledge of diet and nutrition, as well as practical skills, for example, cooking skills, directly through these activities. But they're also potentially improving their knowledge of diet, nutrition, and practical skills through the formation of kind of informal networks with other parents and carers, which they've made through these interactive community activities and outreach activities, which has really enabled that kind of informal sharing of knowledge and advice, and informal networks of parents and carers being able to connect with one another. So this pathway also hypothesizes that these activities and outreach might help families in actually accessing affordable food and healthy food. So I think this is something we've seen in more recent years with the cost of living crisis and things like that, where there's been a bit of a shift to really focusing on how services can support families to access affordable and healthy food. So through food clubs or pantry services and that sort of thing. And then for both of these mechanisms, kind of moving along the chain, we hypothesize that these really lead to enabling parents or carers to make positive nutrition and diet choices, which in turn lead to families kind of establishing and maintaining healthy feeding practices. So it's about making positive choices and then really establishing and maintaining those within the family. So again, I'll hand over to Objective 1, who will explain how their evidence will speak to this pathway. Lisa.
Thank you. So yeah, for Objective 1, we are looking at a couple of indicators for children related to the outcome area of diet and nutrition that are mostly measured early in childhood. So starting from early indicators at the time of birth through to outcomes for children in early infancy. So the first outcome indicator we're looking at is smoking status of the mother at delivery. So indicating whether the mother was reported as being a current smoker at the time of delivery, which may influence children's early growth. Then next, we're looking at gestational age of the child at birth. So whether the baby was born preterm, so before 37 weeks of gestation, which is another risk factor for child nutrition. Then we are looking at the birth weight of the child. So this is an indicator of whether a child or a baby born at term, so at or after 37 weeks of gestation, is identified as being low birth weight. So has birth weight lower than 2.5 kilos. And the final indicator we're looking at is breastfeeding at 6 to 8 weeks. So whether infants were totally or partially breastfed when they were 6 to 8 weeks old. So those are the indicators we're looking at for Objective 1, and I will pass on to Natasha for Objective 2.
Thank you. Yes, so Objective 2 can give evidence for this top pathway. So the findings from Objective 2 interviews with practitioners showed that community initiatives were successful in delivering information about healthy living in an accessible and engaging way. So initiatives like food clubs served a dual purpose. They both offered good quality, low cost food, whilst also embracing the social benefits of the community activities. And ABS staff really encouraged families to get to know each other through activities like communal food preparation sessions. And as well as providing families with important access to healthy food, ABS respondents also explained that these activities helped families to develop connections with other people, reducing their social isolation. And it brought together families from different backgrounds, allowing them to learn about different cultures and share each other's recipes. ABS services offered a personalised approach, and they ensured that advice given to families was culturally appropriate and also tailored to families' preferences and customs. And at the same time, services equipped families with information about healthy eating through practical activities, and that gave them the skills and confidence to prepare nutritious food at home themselves. Community was also a really important element of some services focused on infant feeding. So, for example, breastfeeding support led by peer supporters meant that advice was provided by someone relatable, which is a really appealing way to receive information and advice. And activities being delivered in the community rather than clinical settings was also considered really important, although it wasn't always possible. One respondent described facilitating a walking group that helped mothers feel more confident breastfeeding in public, whilst also building their social networks. And these opportunities for social connection and shared experience were thought to be quite effective ways of promoting healthy lifestyles and creating positive messaging around behaviour change. So I'll just hand over to Objective 3.
Thanks, Natasha. I'll stick with the focus on breastfeeding, although it's worth saying we have lots of examples in the Objective 3 data that align with those key points that Natasha was highlighting. In relation to breastfeeding, there's evidence in the international literature that the nature and quality of support from community services and healthcare providers is a really critical factor in facilitating breastfeeding. For example, Beggs and colleagues' research in 21 showing that support that's inadequate, impractical, or infused with conflicting messaging often undermines breastfeeding practices or risks undermining breastfeeding practices. So one of the things in light of that evidence, one of the things that's striking in our data over time and across all 5 of the ABS partnership areas is that perceptions of breastfeeding support have been consistently positive and enduring. So mothers have overwhelmingly said that ABS breastfeeding support was relational, flexible, and responsive to individual family needs. And in several cases, that was true over prolonged periods of time. What's crucial again is that support is flexible, and our data also show that it's not simply a case of teaching someone to breastfeed and then once they know how to do that, they won't need further support. And again, that's illustrated in interviews with families over time. So to take one example of a mother who has very limited extended family support, she described herself as having been the first in her family to manage to breastfeed her children. In her Wave 1 interview, she spoke at length about the role of ABS support in achieving that with her first child, including the identification of a tongue tie and support through an ABS breastfeeding service. By the time of her Wave 3 interview, she'd had her second child. That's one of the delights of longitudinal data, is the new children join the study over time, join the evaluation over time. Again, with her second child, she'd relied on support from the same ABS service to establish successful breastfeeding again. In both interviews at Wave 1 and Wave 3, she talked about the struggles she'd faced and used remarkably similar language. For example, talking about endless nights where it was like, go and get the formula. No, don't do it. And she warned that while some people might just take to breastfeeding with a bit of support to get started, she said, there are people like me who even second time around, it wasn't easy. It just didn't work again, and I thought it would. Reflecting on potential changes to local provision following the end of ABS funding, she also expressed concern about the potential impact on rates of breastfeeding in her area. So I'll hand over to Beth.
Thanks, Janet. As Lisa mentioned, one of the outcomes that Objective 1 is measuring is breastfeeding. And in Objective 4, we've found evidence from existing cohort studies and from economic research that breastfeeding at 6 to 8 weeks reduces the risk of obesity for children aged 4 to 5. And that has a knock-on effect on incremental healthcare costs during childhood. That means that if the Objective 1 analysis finds an increase in breastfeeding rates at 6 to 8 weeks, then we can estimate the corresponding healthcare costs avoided during their primary school years. And looking at the other outcomes then that Lisa measured, there's also evidence that smoking in pregnancy leads to increased child healthcare costs through greater use of primary care, prescriptions, and inpatient services. Therefore, if Objective 1 analysis identifies a reduction in smoking during pregnancy, we can use that evidence from existing economic studies to model the potential health sector costs that could be avoided if fewer children had these related health issues during their primary school years. Low birth weight is another outcome, ABS outcome, and it's associated with A, an increase in childhood illnesses and corresponding costs of healthcare services to deal with those, and B, delayed communication skills measured as a low vocabulary at age 4, which increases the need for speech and language therapy. So again, if objective 1 finds a reduction in the proportion of 2-term babies who are born with a birth weight of lower than 2.5 kilograms, then we can estimate the potential costs that could be avoided in relation to these healthcare and speech and language costs. And finally, in terms of gestational age at birth, preterm birth is associated with an increase in childhood illnesses and associated healthcare costs during childhood. So if objective 1 identifies a reduction in the number of preterm babies born in ABS wards, then we can use our model to estimate the potential health sector costs that could be avoided if fewer children had related health issues during their primary school years. I'll now just pass back to Mary.
Great, thank you, everyone. And yeah, just reflecting on the examples that were provided about breastfeeding and the support that families were given through ABS for breastfeeding, I think it really illuminates A Better Start's ambitions to work in partnership with families and within communities to really maximize the opportunities of not only working towards increased breastfeeding rates, but also the social aspects and really mobilizing around the community and the social aspects of eating and dining together, even at the early stages of infancy in a family. So moving on now to social and emotional development, I'll hand back over to Mackenzie.
Great, thanks, Mary. If we can go to the next slide, and then the next slide after that. Great, thank you. So once again, for the final time, I'll explain the pathway diagram here. So for social emotional development, so for this outcome area, we also hypothesized 2 different causal pathways to explain how ABS might contribute to social and emotional development. Today, I'll speak through the second pathway, which is on the bottom here. So for this outcome area, the blue box suggests that ABS services provide direct and tailored support to parents, carers, or families related to social emotional development or support for families during difficult times. And this support is often focused on early identification and intervention. So we hypothesize that this can lead to improved knowledge, skills, and confidence amongst parents or carers in relation to child social and emotional development. So this is about really providing, giving parents and carers more knowledge about how children develop social and emotional skills and things like that, and how what they do in the home can contribute to those things. This pathway also hypothesizes that support leads to earlier identification and referrals to tailored or specialist support for families. So that's families with complex needs or who might be going through difficult times and just need a bit of extra support. And this is identified either kind of directly through the ABS support, the services that they're accessing, or we're hypothesizing that it also could be identified by parents or carers or families themselves through this improved knowledge, skills, and confidence in relation to child social and emotional development. So by developing their own skills and knowledge and confidence, parents might identify earlier areas where they might need extra support and that sort of thing. So for both of these mechanisms, we hypothesize that they lead to a further mechanism around parental resilience and well-being, and a reduction of stress and anxiety, which again, we're hypothesizing leads to improved bonds and resilience among families. So once again, hand back over to Lisa for objective 1 to speak to this pathway.
Thanks again, Mackenzie. So yeah, for objective 1, again, similar to the other outcome areas, we'll be comparing indicators for children and families in ABS partnership areas to those outside of ABS areas to look at the evidence of impact of ABS. And for the outcome area of social emotional development, we will be looking at first perinatal maternal mental health. So we'll be looking at depression and anxiety and measuring whether mothers reach thresholds for anxiety or depression in their perinatal mental health assessments. So this will be looking at the generalized anxiety disorder score and the patient health questionnaire, or the HOLE scores for depression. We will also only be looking at evidence of impact in the postnatal period using these measures. Then next, we will be looking at children's socio-emotional development at 2.5 years or 30 months. So depending on data availability, we may use either the ages and stages questionnaire and the separate social emotional questionnaire measure, or we may look at the personal social domain captured as part of the overall ages and stages questionnaire at 2.5 years. And similar to what I mentioned for communication and language, we'll be looking at whether children reach the expected level of development in this domain for this outcome indicator. Then we're also looking at two other measures that were covered earlier. So the overall ASQ, or the ages and stages score, also covers personal social development in addition to communication skills and gross motor skills, fine motor skills, and the other domains. So this measure and the school readiness measure both capture aspects of social emotional development in addition to the communication and language domain. So these outcome indicators will also speak to this outcome area on top of the communication and language outcome area. And finally, we'll also be looking at child abuse and neglect outcomes. So for this one, we will be measuring this using the incidence of A&E attendance or emergency hospital admissions for children aged 0 to 4. So these are the outcome areas we'll be looking at, or the indicators we'll be looking at in Objective 1 for this outcome area. And again, I'll pass over to Natasha for Objective 2.
Thanks, Lisa. Yes, so we've heard from ABS respondents about a range of universal play-based activities which enhance social and emotional development, but I'll just focus on the targeted early support, which included parent and infant relationship support and infant mental health services. So respondents saw these targeted interventions as a key area where ABS filled a gap or added value to the existing local authority service offer for families in the antenatal period. ABS respondents emphasised the importance of families receiving support as soon as possible, both to prevent reliance on statutory services later and also to help families develop the skills, confidence and coping strategies to be able to manage their children's behaviour. And importantly, services addressed parents' own emotional difficulties or referred them to other support services to ensure that underlying causes were being addressed. And respondents talked about how supporting parents individually was also a crucial step in working towards developing a strong parent-infant relationship. And the ABS approach offered flexibility for ABS services to tailor their offer to families. So, for example, a practitioner from an infant mental health service described how spending multiple sessions on assessment and connecting to families' stories help them to fully understand their needs and provide a personalised support plan. And they were able to draw on evidence-based interventions and multidisciplinary teams to ensure that they were providing the right support for families rather than a one-size-fits-all approach. And ABS respondents also discussed working with partners to ensure that there were smooth transitions out of ABS services, for example, working closely with public health and community partners to make sure that families could continue to access support if needed. And the combination of that tailored support, the skilled practitioners and signposting to other services meant that families received holistic support, helping parents to build the resilience and resources needed to foster a positive bond with their child. Over to you, Janet.
Thanks, Natasha. And again, I think the data that we're seeing from Objective 3 really aligns with those points that Natasha's making. The final example that I want to share relates to a point that I made earlier, that just because support's been effective for a family, it doesn't mean it won't be needed again in future. And I think that message is particularly important given what we know about the complexity of families' lives and the intersecting challenges that they face, which are very often exacerbated by poverty, housing, and financial insecurity. Having said that, it was equally clear that the benefits of support did endure for families. And the final example that I want to share relates to that. So this example comes from a large family with children spanning a range of ages. And because of that, they've been involved in ABS over many years. And in her Wave 3 interview last summer, the mother in that family reflected on her early experiences of ABS. She spoke specifically about the ongoing value in her family life of an ABS parenting course that she'd attended with her sister 8 years ago. They attended, that was prompted by challenges that her sister was experiencing with her toddler at the time, but which she said had equipped them both with resources that they continued to use over the years. And I think it's striking that she chose to talk about this course 8 years on. Its ongoing relevance for her parenting and her family practices was highlighted by the way that she spoke about it in her interview. So she included a lot of detail in her account, describing particular activities that they did, the provision of a creche that allowed her and her sister to focus, and the specific behavioural challenges, the examples that were given in the course that they discussed. What was also very striking in her narrative was that as she talked about it, her language shifted from the past tense to the present tense. And as she concluded her account, she reflected that it taught her and her sister, and I'm quoting, "This is how you do it." Because then we both stuck together doing it. It's like, this is how we do it. So you can see again that joint engagement in their experience, but also that this is still how she's doing it with her younger children 8 years later. So back to Beth.
Thanks, Janet. So linked to this parental resilience and wellbeing aspect within the pathway that's currently on the screen, there is evidence that perinatal anxiety and depression increase the risk of children having emotional and conduct issues, which have associated costs then for intervention through social services, healthcare, and education. Therefore, again, if Objective 1 finds evidence of improved perinatal mental health, then we can estimate the potential costs that could be avoided if fewer children required these interventions during their primary school years. There's also evidence that children with an at-risk ASQ for social and emotional development at age 2.5 have a lower social and emotional development, continue to have lower social and emotional development at school age, and also higher risk of conduct disorder, ADHD, and internalizing problems, which lead to additional interventions and associated costs during their primary school years. And those costs are mainly relating to frontline education and special education. So if Objective 1 identifies a reduction in the number of children with an at-risk ASQ social and emotional development score, then in Objective 4 we can estimate the corresponding costs that could be avoided for this group. Thank you. So I'll now pass back to Mary.
Great, thank you, everyone. Yeah, so that was the final claim that we're presenting in the webinar today, and I think that that's a really nice one to land on to finish in the discussion of the mosaic of evidence, because it highlights the the elements of ABS which provide ongoing support for an outcome area that isn't a one-off. Social and emotional development continues throughout a child's life. And I particularly like the example that highlights the support out of ABS services and ways in which families were supported through that transition process. So we're going to move on now to discussing next steps, and then we have some time for conversation. But the next steps for the national evaluation are we are working towards a final report being published in spring 2026. So at the moment, we are completing our analysis across the objectives, as well as synthesizing local evidence and using all of that to conduct the final contribution analysis. So in 2026, the final results will be published. And then thank you to everyone who's posted questions and who's posted questions in the chat. We will be able to respond to some of them now. So if you can move on to the next slide, Irina. We can respond to some of them now, and for those that we don't have time to respond to now, we will take away and write up responses to and publish them alongside the recording. But to start, Mackenzie, there was a question for you about how the contribution claims were developed, and I think that would be a nice one to kick off the discussion. So if you could read out the question and then give a response.
Perfect. So the question was, could you explain further how the contribution claims were identified / defined? Where did they originate / who were involved in defining these? The researchers alone or also partners or those involved, etc. So this gets back to kind of the 6 steps of contribution analysis that I was talking about earlier. So they really originate from the theory of change. So the theory of change identifies kind of the key outcomes that ABS is trying to achieve. So that was work that was done in that first phase of the evaluation, really kind of scoping work to make sure that we fully understood what ABS was trying to accomplish, and particularly the outcome areas that they were looking to help change. So those are the particularly the 3 child outcomes that we've presented on today, but also systems change, and that term has kind of evolved into a few different claims. What we had on the slide earlier, but we've got 5 different claims about systems change around joined up working, increasing parental engagement through co-production, adaptive and evidence-informed services, shift to preventative services, and then adoption of ABS approach beyond ABS areas. So those the child outcomes have remained the same throughout the evaluation, but the system change ones have shifted slightly. But how we've developed kind of the full contribution claims, so we had initial drafts of these claims in spring 2023, and those were informed by those first kind of waves of evidence that were collected, particularly from objectives 2 and 3, because objectives 1 and 4 were still kind of waiting to gather evidence. And so those, because it was objectives 2 and 3, those were very much informed by evidence from practitioners, so who are working within ABS areas and on ABS services, and some non-ABS services as well, and some non-ABS areas, as well as from objective 3, the evidence from families. So while they weren't exactly involved in the exact development of the claims were very much informed by that evidence. And since that point, we have further developed the claims based on new evidence. So the claims have become much more intuitive and covering more of the data and more pathways than we originally had based on the first data. And I think that also reflects some things that have happened since then. So things like COVID and cost of living crisis and things like that. But ultimately, the process of developing the claims started really working backwards from the outcome areas. So what are the outcomes that ABS is looking to achieve, and then trying to tie together the different elements that that we're seeing throughout the data. So what are the inputs and activities that ABS have been implementing that might lead to these things, and then really trying to tease out the different mechanisms from the data, particularly from objectives 2 and 3. So I hope that helps to explain that a bit more. I'll hand back to you, Mary.
Great. Thank you, Mackenzie. Before we move on to the next question, I just want to respond that there was a question came through about whether detailed notes will be shared following the session. In addition to the write-up of the Q&A and the recording, we will also be sharing additional resources such as the National Evaluation Protocol and where you can find all of the annual reports and other outputs and other interim outputs. So there will be other sources of information for this. This was more of a technical question about the quasi-experimental design for Lisa. So would you be happy to answer the question about how comparator area data are being analyzed?
Yes, sure. Thanks, Mary. So I can read the question. It's for objective 1, is data for the comparator area being analyzed at the whole area level, or have individual families been selected? So the quasi-experimental analysis approach for objective 1 will be using individual level data, but we will be using this to consider effects and outcomes across children and families exposed to ABS, and on average compared to those in non-ABS or non-ABS areas. Depending on data availability, the analysis will focus on different groups. So either we will be looking at all residents of ABS partnership areas compared to residents of areas outside of ABS partnership areas, or we will be looking at children and families who were program beneficiaries in ABS partnership areas and comparing their outcomes to those in non-ABS areas. So we do refer to these different analysis approaches or groups in more detail in the annual report. So do look there if you're interested for more details. Thanks, Myra. I'll pass it back to you.
Great. Thank you, Lisa. And Natasha, there was a question about the focus of training and and kind of the relationship between building capacity within professionals as well as parents. So would you like to respond to that question?
Yes, I can. So yeah, this was related to the communication and language pathway, which I talked about, training for practitioners. We did also hear from respondents who talked about supporting practitioners and staff within nurseries by showing them how to in turn support parents. So they talked about how a lot of the time staff in earlier settings do have the experience and understanding themselves about communication and language, but an area that is more difficult is supporting parents to develop those rich home learning environments. So for this one particular person we spoke to, they had kind of a 5 to 6 week program with practitioners where they were walking practitioners through different tips of how to support parents to do that with their children, and that was quite well received. So this is obviously a really important element of kind of cascading the learning from ABS training, ensuring that parents can continue to apply the same approaches with their other children as well, even after ABS has ended. And I think an element of the question was about fostering parents' resilience too. And although that wasn't a kind of key focus of the intervention that I've just talked about, signposting is a really big element of the ABS approach. So staff would be encouraged to kind of help participants find additional support, maybe from social and emotional services.
Great. Thank you, Natasha. And Janet, I was hoping you'd be able to respond to the question that was posed when we were discussing the social and emotional development claim about fathers and their involvement in developments and activities.
Yeah, happy to do that. And it's worth saying that we took fathers' experiences as a particular focus in the second annual report, which is published on the NatSen website, where we did, as part of our, I think it was our Wave 2 fieldwork, we did separate additional interviews with fathers to get their perspectives. We also include fathers in our interviewing as part of the household interview if they want to take part. And in a couple of cases, fathers are our primary respondents. And fathers are involved in activities in a range of ways. So there are, in some cases, there are activities that are specifically targeted at fathers for fathers to attend with their children. And some fathers really appreciated those. Other fathers, I think, were quite happy just to participate in other activities that were going on anyway. So not specifically father-focused activities, but just some of the group activities that Natasha's referred to that people have taken part in. And they've talked about those. One of the other things that was interesting that fathers also often valued, which relates to the contribution analysis discussion of mechanisms that lead to change and about flexible and targeted approaches where additional needs might be identified, is that fathers also often particularly valued when there was targeted family-focused support. So we have some examples in the second annual report of, for example, where there were diet and nutrition concerns about child growth in one family, speech and language developmental concerns for another family, where there had been work with the family within the home, focused on their needs, focused on strategies that they could use as a family. And several fathers talked about that as being something that they found particularly valuable as well, to not be left out of those discussions, for that to be organised so they could be included in that. And I think the other thing that's just quickly worth mentioning in relation to that is that we also have some information. There's another question about domestic violence and estranged and non-involved fathers. We haven't interviewed fathers where they're not resident in the child's primary household because of the ethical sensitivities of doing that in a study of this kind. But we have got data from families where they have been involved in specialist domestic violence services that they've been linked into through A Better Start. So that is something that we have insights into as part, I think, of a wider set of insights that we have about families where there are more challenging, more complex child and family welfare needs. So hopefully that covers.
Great, thank you. Thank you so much for that, Janet. So we have a question about the emphasis of engagement strategy, about the importance of engagement strategies that have been used, and in particular their emphasis on co-ownership and co-production. And I think that's quite an interesting topic that several of us would be able to speak to. But Mackenzie, I was wondering if you could start us off. Would you be able to start us off and discuss that in relation to the contribution analysis?
Definitely. So I think that's a really important question, an important topic. We have a contribution claim specifically within the systems change claims around co-production and parental engagement, really focusing on, won't go into too much detail now, but kind of a holistic approach to support and how ABS services are really identifying and working with parents to identify needs and really tailor services to ensure they're kind of meeting parents and families' needs. But then also this kind of secondary pathway around providing actual opportunities for parents to get involved in real co-production and have a voice and have almost a leadership role within some of the services, and also inspiring parents to even develop their own services and things like that as part of the program. So we'll definitely, that will be something that we expand on quite a lot in the report, as we have a separate claim on that. But I also think it's a really good example of one of those systems change elements that is also a mechanism within the child outcome areas as well, because I think we see, you know, a lot of what we see within the claim pathways that we presented today is about parents and getting parents involved with services, with each other, and that sort of thing. So I think within a couple of the claims, we really focus on this idea of kind of interactive community activities and outreach and things like that, where I think we heard through the work that parents in ways kind of preferred those more interactive activities rather than kind of just being taught at or taught something where they can really get involved with the activities that they're doing and with other parents and carers as well. So yeah, I think that's just a really good example of where kind of systems change. That is something we're focusing on as its own claim, but it's also inherently within the child outcome as mechanisms within that. So I'm not sure if anyone else wants to comment on that one.
I'm happy to come in on that one if it would be helpful. I think I mean, I agree with everything that Mackenzie's been saying. I think you see it very, very clearly in the family data that we have, that sense of ownership and partnership that particularly the most involved parents have is not only beneficial at a systems level, and we hear lots of examples about people helping to shape the nature of services, highlighting needs, being able to signpost other parents in their community within parent champion roles, for example. But we also have examples in our data, several examples in our data of parents talking about, for instance, how that experience, parents and carers, actually, I would say not only parents in the sample, how that experience has helped them in dealing with difficult circumstances in their life. So in some cases, that's very concretely around supporting career development, leading people into training and work opportunities, but also in giving people a sense of identity and purpose when other things are very challenging. So actually people discussing quite concrete benefits on their emotional well-being of having that identity of being part of something. So the co-production and engagement is a really important part of that. I guess the other thing that I would add to that, really underlining that question about the importance of the engagement strategies, is that we did some specific analysis, which is in the third annual report, looking at different pathways to engagement and some of the barriers and facilitators of engagement for families in different circumstances. So that's worth, I'm conscious of the time, so I won't start. Mary knows how much I like to talk. I won't start going into that now, but if you're interested in learning more about the importance of engagement, that's probably worth reading.
Great, thank you so much. And the there was just one more question about when the QED results are going to be available that I can respond to now. We're going to publish those in the final report in spring 2026. And then the rest of the questions that people have submitted, thank you very much. We will go away and reflect on those and respond to them. Respond to them in writing along with all the questions that have been asked, so that everyone can benefit from the Q&A in this session who watches the recording. So just before we close, I'd like to signpost you to some more information. So Irina, if you can move to the next slide, please. Where have my slides gone? Mhm. Mm. So I've put a QR code here that will take you to our website where we host all of the outputs for the national evaluation. Uh, Particularly related to the content of today's webinar is our most recent podcast, which is about the contribution analysis and mosaic of evidence. You will also find the National Evaluation Protocol, which goes into the methods in more detail than was possible to present on in a short webinar today. And we also have published 3 annual reports as well as annual blogs and some practitioner-facing briefs. So please do check those out for more information, and we'll look forward to sharing the final results with you when the evaluation concludes next year. So, thank you everyone for joining.